All right, Clarisse. Clarisse, where are you from originally? Where'd you grow up?
I'm from Chicago.
Tell me about your family growing up. You had mom and dad?
Mom and dad, older brother. Um, it was, yeah, I mean, basic enough childhood. If you look at my first couple psych ward stays, all those records say that I had a very good childhood, good, stable childhood.
What made you want to become a psych nurse?
Well, I went into nursing initially because I love science and I love people. And I didn't think I was smart enough to be a doctor. So I didn't also have the patience to be a doctor. So I thought I was going to be a surgical nurse, actually. I wanted to see surgery. I wanted to see the blood, the gore, all that type of stuff. And then I went to one surgery in nursing school, one C-section, and I just thought, I'm like, this is freezing. This is boring. I don't want to stand this long. Like, those surgical suites are really cold. So immediately I'm not doing that. And then I did my rotation in psych. And I had sworn off psych at this point, mind you, because I had been hospitalized right before I went to college. And I said, hell no, I don't want to be anything near a psych. That's not me. But I went to my first psych clinical, and the people there, okay, in psychiatry, in most of nursing, you listen to the doctors, you don't just take orders, but it's not quite like psych. In psych, the beginning of the day, we do rounds. So everybody sits at a table, doctors, therapists, everybody, and the nurse gets to run it. So I get to sit there and I get to tell them exactly what's going on, my opinion, what we should do, all these things. And I'd never seen that in any other part of nursing, having that equal of power. And that really intrigued me because I wanted that team environment. And then I started talking to the psych patients and relating to them in many ways and understanding that, it kind of takes one to know one, I guess. And when you go through a hospitalization process, it's really hard. And it's really hard to understand that unless you've been through it. And having that insight made me a very good fit for the job.
And you're treating patients who are similar to the people I interview, probably people on the streets?
Yeah. I've worked at a few different facilities. So I started in the public hospital system in New York, and that is what you'll see are most typical, what we consider crazy on the street, talking to themselves, yelling, potential for violence, but it's just the quintessential, you think schizophrenia, you think psychosis, you think yelling on the subway. That's who I'm treating. But I'm also treating alongside them. Like I could have one room with a homeless person, the next room with a sexual assault victim who may or may not be homeless, and then I have next to that, I'll have like a businessman. I have a white collar individual. I remember specifically there was one, all he wanted to do was talk about the stock market because he was so depressed, came in for a suicide attempt, no family, no wife, no kids, nothing. All he knew was finance. He knew how to predict stocks. He knew how to make money. And that's what he was good at. And he asked me every day to print out, is it the Dow Jones? Is that what it is? Mm-hmm. To print out all of that stuff every day so he could look at it. And I would talk to him because I'd stay late sometimes and just talk to the guy. And I found out that pet food is a good thing to invest in, even in recessions, because everybody buys pet food, and beauty products. Beauty products are very good because you're still going to get your makeup. But yeah, I mean, you learn crazy stuff from these people all the time. You learn so much different stuff.
And what separates those people that are in the facility from the ones that are on the street? How are they so lucky to get treatment?
Well, it's interesting, actually. I worked in the psych ER. It's called CPEP, not CPAP, CPEP, Comprehensive Psychiatric Evaluation Program. Yeah. And I worked triage there. So I was the first person up front that decided, are you even going to get back to the doctor? Or are you going to have to go back out on the street? And that is a really interesting position because where I was working, you had not only people coming in psychotic, suicidal, or homicidal, you had people trying to come in to traffic people, to sell drugs, to do those types of things. And they would see the vulnerable population in a psych ward and want to jump on that. So you would have older women being taken advantage of, older men, all these different things, younger women being trafficked, all of this different stuff. And it was my job sitting up front to say, like, can you come back or not? You got to suss out the line. And unless you are an extreme case, like, especially in these days, unless you are actively a danger to self or others, most of the time you're not going to get admitted. There's other criteria, but it's pretty high bar to get admitted to the hospital for psych. It is, when you're in the psych ward in an acute hospital, it's pretty much the ICU of psychiatry. So
yeah, it must be difficult because there are so many people who are out of their minds that are on the streets.
And actually, the bigger problem that people aren't really talking about is kids. We have a lot of adult beds. We have a lot of adult psych hospitals. We don't have that many kids ones. We don't have many people wanting to go into kids. And we have a huge problem with mental health with teenagers and younger kids these days. COVID.
Where do they end up?
They end up in the psych ward as well, but there's far and few beds in acute psych hospitals.
So the ones that can't get beds go where?
They end up in the emergency room for 2-3 weeks, months sometimes. I heard of a case that I had once where this little boy was in the emergency room for 2 weeks. And in the emergency room, you don't have any psych care. You don't get therapy. You get sandwiches, you get juice, and that's about it. It's an emergency room. It's meant for temporary stays. But these kids don't have beds, so they'll either go to the medical ward, not get their psych care, or stay in the ER. Or worse comes to worse, they just get discharged right back out until something worse happens. You get someone, like a lot of kids will come in and they will be self-harming. But there's not a bed unless they are literally trying to go for a artery. We have to push them out and we have to push them to outpatient. And then it is so frustrating because you have kids who are from DCFS and they don't have placement. It's called placement. So they will stay with me first up. I had one for 9 months in the psych ward that's not leaving the psych ward. That's not leaving that little unit, not going outside, not getting sunshine, any of that. And there's just not enough resources for the kids either outside or inside the hospital. And the wards of the state are just, I feel for them so hard. Though some of those have broken my heart in the past.
What do we need as a country? I think we used to have mental health facilities for this.
In our history, we had very abusive state-run facilities. And instead of trying to make those better, we decided to shut them down and push everybody on the street. And that's a huge reason we have this massive homelessness problem. Now, to say keeping them in an abusive environment, that's horrible to do. That's not necessary in any way, shape, or form. But to push them onto the street, is that really more humane? Because once they go on the street, they're just cycling in and out of this what's it called, like ICU care of psychiatry. They're never being stepped down to the appropriate levels. How it's supposed to go and how it was planned to go before Kennedy got shot, essentially, was that they were going to close these big state-run facilities and make community centers. And so you could step down from this acute care, which is the inpatient psych ward stay. You go to a residential treatment facility, so you're still being monitored 24/7, but you can leave and you get some of these it's a less restrictive environment. You're still getting your meds, still getting taken care of, but you have a lot more liberty. Go from there to partial hospitalization, which is day programs. You're there for all day, 8 to 8 sometimes. And then you go from that to intensive outpatient, and then hopefully from there you can just do your weekly or biweekly therapy. It's a very process that we have established. There's so little resources along those steps. And we don't want to treat it until it's super severe. We don't want to intervene until somebody has their wrist cut, until they try to push someone off a subway platform. It takes that kind of event for us to be able to admit them. There's a lot of patients that I've wanted to keep, that I've wanted to admit, that I've wanted to hold longer because they needed more help. But insurance ran up. They didn't have a criteria. These things get in the way. When insurance runs up and you have to kick a patient out who's not ready, that is brutal. And that's our job as nurses. We are the ones who call security if they won't leave. You have to turn off that caring part of you. And it's hard to do that. It's hard, those situations, when you have the reality being hit there.
As a caring person, how does it affect you to be working in this field and doing things like that? I tell the new grads because I'm a preceptor, I tell them if you're having trouble week 1 with this emotional aspect of it, you should probably change specialties.
because it doesn't get easier. You just get more bitter. I pour my all into my work. I care, I give it all, but that needs to shut down when you leave the hospital. You can't worry about those patients. You can't think about them post-discharge. You have to convince yourself every time a patient is discharged, they are going to a great life. They are successful.
What's the truth of it?
Who cares? Because you have to think that way. The truth of it may be, it's bitter, it's horrible.
Otherwise you couldn't do the job.
Otherwise you couldn't do the job. If I let every single one of these patients, if I let that reality really hit me in the chest when I'm going to sleep at night, I could never do this job.
Yeah, same with what I'm doing. Like, I'm seeing so many of these heartbreaking stories. I can't absorb all 8,000 people I've interviewed and their horrific stories. So I have to just kind of numb myself somehow, or not necessarily listen to every detail of every story, because otherwise I'd lose my mind. It's
hard. So they'll tell you just brutal things. I'm writing a book right now. I'm writing a novel about the kids that I've worked with. It's not specific to the kids, but it's a compiling of the stories. Because some of the adults, they'll get to you, not piss you off or something, but they'll hit you a little bit, and you'll worry about them later on. You'll think about them. And there's not too many that have really stuck in my mind where I think, oh, I wonder how they're doing today. But the kids are harder. Because there's a couple now that I still wonder about. And I remember the first time a kid kind of touched me, and I was thinking about him, and I went home that night. And I was worried for this little girl. She was getting discharged to a group home. She had been under my care for 6 months or something. She was so excited to go to this. She was so excited to go to this facility that I knew was horribly abusive and was going to really fuck up this beautiful, innocent little girl in front of me. 12 years old, wonderful. I can still picture her smile. And she was so excited just to leave the hospital, and she was going to hell. And I remember I gave her a note saying, I give some of the kids these notes of advice, these little things. And I gave her one that said, it was like, stay amazing even if people can't handle it, something like that. It was a Calvin and Hobbes cartoon where it said, I think it was like, Hobbes says, Calvin, what are you doing? And he says, I'm being cool. He goes, well, you look bored. He says, well, the world bores you when you're cool. And I gave that to this little girl and said, even when the world gets boring, stay cool. And that's all you can do. You can give them a little note, you can give them advice, and then you hope for the best. But then, it's rough.
It's heartbreaking.
Yeah. Especially when you know those cases. There's a small chance she'll be okay. There's a chance she gets out of there and has a productive life, but most likely she's going to get fucked up. And those are tough. Those are tough cases. When you're working with kids, it's harder to not get emotionally involved with it. But it's also easier in a sense that you can. When you get emotionally invested in the adults, they'll use that against you. They'll turn it. A lot of them are just... You lock somebody up in an environment, you take away everything, their phone, their dignity, their clothes, their possessions, everything. They're going to grasp at any sense of power they can get back. And they'll do it desperately in many ways.
And if you show that you're kind-hearted, they will.
Oftentimes they'll use that against you.
Yep.
They will totally turn that on you. But with the kids, they can try, but the 16-year-olds aren't good at it yet. They're not that great at turning your words on you and everything else. So you can be a little more genuine, be a little more open with them. And because of that, you connect with them more on a deeper level. It's not so much the nurse-patient as you are taking every role that kid needs in that moment. The big sister, the cousin, the aunt, the uncle, and in some cases you're taking the mom role, which is hard because you're still the nurse. And you have to separate those two. You're not allowed to hug the kids. And imagine a kid breaking down in front of you, just sobbing, horrible thing. Like, I had a little boy, my dad doesn't want me anymore. I can't go home. He's just giving me up. This little boy, it was a bad case.
And you can't give him a hug.
I can't give him a hug. You can't give him a hug. You can't, and I understand why, because that breaks the boundary and there's the attachment and all that. But in that moment, you just want to hug that kid. You just want to give him a hug and try to make him feel a little bit better. And it's tough. I've had kids just run up and grab me, and really, you can't just like shove them off you, but you can't initiate any sort of touch like that, and it's tough. I understand where all these rules come from. I understand all these things, but when you're in the moment with a kid sobbing in front of you, you just want to give him a fucking hug. Yeah.
I'd lose my job in 2 weeks.
Yeah, right? Yeah.
What are some of the most memorable cases that you've seen? It's got to be depressing, I'm sure.
Well, I mean, how do you want to know memorable in which way?
Well, like people that either you've helped or people that clearly needed help and just got pushed out.
There's this one little girl who, anger problems, horrible anger problems. She had been assaulted by a family member, went to court, and they let the guy off. She testified everything. She testified that he raped her and this and that, and the guy got off. No charges, like he was just completely let free. And when that happened, she got admitted to the hospital because she really just broke down. And she would punch the wall, she'd kick the wall, she'd bang her head. She just wanted to hurt herself. She wanted to cause damage to herself and everything around her. And I struggle with anger. Was a very, very angry kid. And because of that, because when you're such an angry person, like I get fucking furious. But if you can calm yourself from that, you can calm anybody down. Like I can calm down anybody. And my de-escalation, fucking hell, I'm very good at it. But this little girl had no idea how to regulate her anger. So I started working with her very closely, and we started punching the mattresses. So I put a mattress on the wall, and she'd punch it and punch it and punch it. So that way she didn't break her hand. She already sprained one wrist. So I had her punching the wall, and we would punch together because she would kind of break down. I'd be like, yeah, punch harder, get it out. And then one day, I punched the actual wall. And I'm busted open bleeding, and I'm like trying to hide it from her. I'm like, ah. And I come back the next day all banged up, and she's like, oh no, it's my fault. I'm like, no, it's not your fault. So later in the day, she has a breakdown, and we're sitting like this on the ground. And as you see, I have these tattoos. I got tattoos everywhere. She's sitting right next to me, and I noticed that she's got, hairy arms. For a woman, she's got hairy arms, as do I. I'm Italian. I got some hair. So we're sitting there, and we're at a pause in conversation, and I say, and when you're older, you can get tattoos on your arms, and your arms don't look so hairy. And she looks at me, she goes up, and she breaks out laughing, and I'm like, it was such a good moment, because I'm like, we related over this one little thing, and then she would tell me about all the tattoos she wanted to get later on. They were better than originally. We talked about them. There were some bad ideas. But she was a wonderful kid. And when I discharged her, she told me, you made me want to live again. You made me want to go on. And hearing that is just, it's insane to hear. It's amazing. When you can turn somebody's day around, their life around like that, and give them some motivation, that makes a huge difference. And I'm a big believer that it takes one person to really turn things around. I got back from working COVID in New York. I went back to Chicago and I still am struggling with it, but I have PTSD really bad because of all the shit that went down there. But there was a point where I was really just ready to throw in the towel. I'm like, I don't know what I'm gonna do. I really don't know. There's no help for nurses after it. That's not like the VA you've got. It's not like veterans where you have all these resources and everything. Public hospital system of New York said, get the fuck out. So I left there, and I found this. I called the city number in Chicago, the COVID helpline. And I'm like, I just broke down to this guy on the phone. I'm like, I don't feel good. And it turns out that he was a veteran and had fought, I think he said in Iraq or Desert Storm or something. I'm not exactly what he's sure he said he fought in, but he had recently gotten a handle on his PTSD. And he talked to me for like an hour this guy at the COVID helpline, which is like for getting a vaccination. This guy talked me down and made me feel so much better. He just, as like, I felt like that little girl, like this guy gave me a reason to live again. He made me feel better about the world, that not everyone is evil, not everything is horrible. There is good people in the world. And I used to think, like, what the fuck was the point of everything that I've done? And then I had somebody do for me what I had been doing for all these people. And it finally clicked. I'm like, no, you can actually, I did make a difference. I did a lot. And it doesn't always feel like it. But just like this guy completely changed my life. And I still call him sometimes. Him and his supervisor, they're just wonderful people. So you really can have a lot of impact just by being nice to people, just by listening.
How have you changed from doing this kind of work? You've been doing it for 9 years.
Yeah, almost a decade in. It's changed me in many ways. Some for the good, or some for the good, some for the bad. I really don't have time for bullshit anymore. When I've had stuff happen in my life, but I don't like gossiping much. I don't like the petty things. When people come and complain to me about their day because they had a stressful meeting or something, I'm like, did anyone die? Because a bad day for me is a kid tries to hang themselves. Like, what a bad day for you? What? Your boss gave you a poor performance review? It definitely puts things into perspective. It's bittered me in many ways. It's both bittered me and made me more hopeful, but you become suspicious of people. My mentor at my first hospital was an ex-detective. NYPD, I don't remember what division he's gonna be pissed at me for not knowing that. He was an ex-detective, and he went back to nursing school post-retirement, and he taught me how to be a nurse, but he also just taught me how to be a cop in many ways, how to really tell when someone's being genuine, when someone's trying to get one over on you, and all these things. And because of that, you become suspicious of people pretty easily, and you become pretty aware of people. Everyone always says to me, are you psychoanalyzing me? You work in psychiatry, are you psychoanalyzing me? I'm like, no, you're probably too boring for me to even try. But it's, you spot things. Like you see track marks when people don't see it all the time. You see like little ticks and stuff that most people aren't looking at. In my family, I have a lot of addiction in my family. And I came back, and I have a family member, and I told my family, I said, he's back on crack. He's using again. 100% he's using again. Nobody believed me. Everyone said, you're crazy. No, he's fine. He's doing great. Fast forward 6 months, 9 months, whatever it was, he's back on crack. He's using again. I'm like, well, of course he is. I told you this. Nobody listens. But you become suspicious of people, and you spot stuff that others don't. And for the better, though, I am the panic button for most people in my life. Like, I'm the emergency contact for a lot of people. And I actually struggled with it for a little while, but most people come to me when they're not doing so hot because they can trust that either I've worked with it or I've been through it. But usually when I get a call from a friend out of the blue, I'll say, like, oh, no, they're not doing well. And my boyfriend once said, he goes, why do you say that? I'm like, nobody calls me with good news. Nobody calls me doing well. Nobody calls me to update. They call me because they're breaking down sobbing. They call me because they're going through a breakup or someone died or something like that. That's why I get the calls. So it's a very good position. I say privileged position to be in, to be able to be there for people like that.
Do you think the cause of their problems is purely from the family they came from, or is it sometimes like genetic things, brain chemistry?
The kids I work with, everybody asks me that question. Literally everybody asks me, is it the parents or is it the genetics? And yes, is the answer.
Yeah,
yes,
both.
It's both. And it's not equal for everyone. Some kids have really abusive homes really, really abusive homes and will come in better states than kids from caring, loving families. And how do you really sort that out? I have read up on it in many ways. There's studies, there's books, all this stuff, but it is both. You can have a really nice home and a kid who's just genetically predisposed to things, and then you have kids who are not predisposed to things, but they go through such trauma. They come in with PTSD. They come in with disorders related to trauma-induced things. Some things like borderline personality disorder is it's not like bipolar where it's genetic and it presents itself through an event. Like if you have a happy, healthy childhood with nothing going wrong, you may not present with these disorders. But if you have a stressful childhood with no intervention or anything else, you're gonna develop these things. I didn't have any intervention in my childhood. I didn't have anything, so I got pretty advanced in my mental illness. My first intervention was at 17 when I asked my parents for therapy. And then my second intervention was after that. I drove myself to the emergency room and then got checked in. But no, nobody said a word to me. Nobody said anything. So, yeah.
What do you wish was different about the way we handle mental illness in this country?
Preventative care is which I wish people would think about more. You have to treat mental illness earlier. So if we were to actually put in place preventative measures for people, like kids who get early intervention are much less likely to have problems later in life. The answer to the mental health question in this country is enormous. It's so many factors. It's the stigma around it. It's the access to care. You know, virtual care has made a big difference because now we can have therapists and psychiatrists doing this from your tablet or computer, whatever it may be. But there needs to be more people working in psychiatry. There's not enough people to man the hospitals. Like even if they were to open up more hospital buildings, who are you going to put them in? Who are you going to man them with? I remember here in New York, they were going to expand the criteria for admission to a hospital. Who is going to be there manning those beds? We were short-staffed every single day. I have never once been fully staffed on an acute unit. Like occasionally, there's probably a handful of times I've had enough staff for things, but especially post-COVID, I have not had anybody. There's a mass exodus of nurses. We already don't have enough of them. Now we're going to put more people into these beds to get worse care to cycle in more and more and more. There's a lot of changes that need to occur. And to get more nurses in there, you got to stop beating us up. Stop fucking hitting us. That's why no one wants to work in psychiatry, because we don't want to get fucking hurt anymore. You know how many times I've been attacked? I don't work inpatient hospital work anymore, even though it's my favorite job, because I'm tired of getting bit, smacked, insulted, attempted rapes, threats of rape, everything. It's disgusting what happens in there, and it's tolerated. You punch a bus driver, it's a felony. You punch a stripper, you're banned from the club. You deck a nurse, I get asked later on, what could I have done differently to prevent that situation? How is that anything? So nurses are leaving in mass numbers because there's no protection for us, and the little protection we do have is inadequate. And you have an influx of patients, so you have an impossible situation here. You can have as many psychiatrists as you want. They don't make up for the difference of all the nurses manning those units. You take away all the nurses from a hospital, it will immediately crumble. But we don't protect nurses right now. We don't seem to care.
And do some of these people, kids or adults, end up just back on the streets?
Most of them do.
Most of them do.
Most of the people you mentioned, most of the homeless people cycle in and out and in and out. It's the revolving door. We have, you call them frequent flyers because they're constantly coming to the hospital. When I worked in Manhattan, there's a line of hospitals that they would go up. They would go 1, 2, 3, and then get admitted, discharged, admitted, discharged, admitted, discharged. And sometimes they'd have all the hospital bracelets on. They'd have like 6 or 7, and I would say, at least take those off before you come to the next hospital. I have to know which one to scan.
And if they were given like medications for schizophrenia, they're not going to continue taking them when they're on the street.
Yes. So a big, I did a temporary position at a ACT team, Assertive Community Treatment. I think something like that. I don't remember all these letters are, but you have to be admitted a certain number of times to the hospital and have a certain number of issues, and then you get a team, which we should have for a lot of people. You have a housing coordinator, you have a nurse, a psychiatrist, and all these other things. And as those patients get what's called a long-acting injectable in medication. So you'll get your risperidone, like an antipsychotic. You'll get your risperidone, Haldol. And then, I don't remember the name of the last one, but you get it, it's long acting. They can last from 2 weeks to 3 months. Invega, that's it. Invega is the long acting. That one goes up to 3 months. So I would carry all these syringes around because you can find them once a month, once every 2 months, whatever it may be. And I would carry probably 5, 6 of these boxes with all these medications in there. They were each like $8,000 a pop, those boxes. So when you have 5 $8,000 a pop boxes and you're walking around East New York, you're just like, please don't take my bag. These aren't the drugs you want. And then I would find the patients wherever they were at. Sometimes I would I'd do an injection like in a laundromat. It was just whatever you can get done. That was a hell of a time doing community care. Another thing, community care is very dangerous. There's not many people who want to go work on the street. Like I remember having someone pull a knife on me once in their apartment, and I had to book it the fuck out and call the cops. And I was alone. Like, when we send people into the community like that, you don't really understand the danger of it until you're doing it. That's a whole nother subject. But
do you see yourself continuing in this field?
I don't see myself going back to bedside nursing anytime soon. I don't see any reason to get hurt anymore like that. I'm thinking about becoming a professor of nursing for psych because it's so necessary. So doing that, thinking about, but I'm actually not really sure what I'm doing right now, making those decisions at the moment.
All right, Clarisse, thank you so much for sharing your story. I hope we, as a country, we do something about it.
Yeah, me too.
We certainly need it.
Yeah.
All right, thank you very much.
Thank you.